Let's look at a challenging case of this 36-year-old male who gave history of blunt trauma 3 years back with complaints of decrease in vision in the left eye with glare and halos. His right eye was absolutely normal. So as we look at the case, we are starting with approximately 5 clock hours of iridodialysis. Iris, because of patches of iris atrophy, had become shrunken. Then he had zonular dialysis and also posterior subcapsular cataract. Now, as we introduced a spatula, there was no posterior synecdoche. So first 2 iris hooks were used to get the iris away from the center to facilitate cataract removal. Capsular excess is done, and slowly lens matter is aspirated. At one point, posterior capsule gets entangled in the aspiration port, but luckily there was no PC rent. Here we can see that there is a significant degree of zonular dialysis. So after removing the cataract, next step is to go ahead and put a capsular tension ring, which was done. This was followed by implantation of single piece foldable hydrophobic acrylic IOL. Limited anti-vitrectomy was done in the area of zonular dialysis. Then after conjunctival dissection, a partial thickness scleral flap is created. Ten-0 double arm Prolene suture is introduced from the main incision and passed through the root of iris and railroaded into 30 gauge needle, which is introduced under the scleral flap 2 mm from the limbus. The other needle is also similarly passed and the 2 ends are tied. As the iris was shrunken, the pupil became quite large. Any further suture to the remaining areas of iridodialysis would have further increased the pupillary diameter. Instead, it was decided to do a pupilloplasty with 10 of Prolene, and suture ends were tied to get a reasonable outcome. Conjunctival closure was done. Patient had a very good visual outcome with no complaints of glare and halos. This is how the patient looked in the post-op period. Thank you.